Okay, this 10-minute topic I'm going to call the osteos, and I'm going to start out with osteoporosis, which is the most common metabolic bone disorder resulting in low bone density. And how this occurs is when there's a rate of bone reabsorption, which is the osteoclast cells, exceeds the rate of bone formation, which is the osteoblast cells, and therefore you get fragile bone tissue and therefore fractures. Osteopenia is a precursor to osteoporosis, and that refers to low bone mineral density for what's expected of a person at their age and sex. So that is a precursor for osteoporosis. So peak bone mineral density occurs between 30 and 35. That's when the bone is the densest. And then after these peak years, the bone density decreases and significantly decreases after menopause, and that's because of the estrogen loss. So what we result in is a fragile, thin bone tissue, which is very susceptible to fractures. So what kind of prevention do we have for this? And what promotion and disease prevention? Well, we want to make sure that our patients have a diet that is adequate in calcium, vitamin D, and that all has to occur prior to the age of 35 when we have that dense bone. The most peak bone mineral density is between 30 and 35, like I said. So we want to make sure that up to age of 35 we have great intake of calcium and vitamin D. We want to encourage our patients to take calcium supplements with the D if the diet is inadequate, like if they're lactose intolerant. So they're not going to get it naturally. They should take a supplement. We want to encourage the client to expose their skin to the sun 5 to 30 minutes twice a week. They just need to get that natural absorption. And we also want them to talk to them about the pros and cons of hormonal replacement therapy postmenopausally, and that needs to be a discussion with the healthcare provider. But we want to encourage our patients to do that, taking the osteoporosis into consideration. And we want to encourage them to engage in weight-bearing exercises as well. So risk factors. Well, we know females over 60 and over 75 if they're male, but over 60 if they're female. Postmenopausal estrogen deficiency, if they have a history of oral contraceptive use, if there's a family history. Usually these are tall, thin, lean, a lean body build. They might have a history of low calcium intake, suboptimal vitamin D, so they never drank milk and they stayed inside the whole time. They might have a history of smoking, a high alcohol intake, increased risk of having osteoporosis, and a lack of physical activity or perhaps prolonged immobility has occurred. Now we can get secondary osteoporosis, and that's from other medical conditions such as hyperparathyroidism, long-term steroid use. So asthmatics might have it if they've been on steroids for a long time, such as lupus. People who have lupus who have been on steroid therapy for a long period of time might develop osteoporosis. And then a long-term lack of weight bearing. So perhaps somebody who has had a spinal cord injury as a young person and they haven't done any weight bearing for a long period of time, they could develop it secondary osteoporosis. But primarily we see primary osteoporosis most frequently in postmenopausal women. As we know, our older population have an increased risk of falls, and that's related to their balance is off, perhaps weakness, gait changes, vision problems, hearing. It can be side effects of medications, maybe orthostatic hypotension, maybe urinary frequency. They have to jump up and go to the bathroom a lot. Maybe they're confused. So anyway, that raises their risk for falls. So that is a risk factor as well. So the signs and symptoms that we're going to see are on the next slide. Signs and symptoms. We're going to see them starting to shrink. They will have reduced height. Acute back pain if they lift or bend, and that's going to be relieved with rest. They may have restriction in their movements and a history of fractures. They could be kyphotic, and on palpation they may have pain over the area that they're complaining of. For diagnosis, we're going to do some lab tests: serum calcium, vitamin D, phosphorus, alkaline phosphatase levels, Those are all drawn to rule out other metabolic bone diseases such as Paget's disease or osteomalacia. We're going to talk about those later. Diagnostic procedures, x-rays, long bones, spine, we're looking at bone density and if there's any fractures or fracture history. A DECA scan, which is a dual energy x-ray absorptiometry, and it's to screen for early changes in bone density, and it's non-invasive, it's painless. It looks at the bone mineral density in the wrist, the hip, and the vertebral column. So what kind of nursing care are we going to be giving these individuals with osteoporosis? Well, we're going to give them their medications as prescribed. We're going to instruct them about foods that are high in calcium, what are good sources of calcium, any kind of information they need to get about taking calcium supplements. They're to take it with food, of course, and instruct the client in the need for adequate amounts of protein, magnesium, vitamin K, and other trace minerals that we need for bone formation. We want to reinforce the need for the exposure to vitamin D, so they need to get out in the sun or they need to drink fortified milk. And we want to encourage them to do weight-bearing exercises to improve their strength and to decrease the loss of bone, such as walking for 30 minutes at least 3 times a week. Because they are at risk for fractures, we want to let our CNAs and our colleagues that we're working with that pathological fractures can occur when we turn and lift these patients, so that we should be using lift sheets and proper technique when we're caring for our patients. We want to encourage the individuals to have safety at home and then also safety in the hospital or the facility that we're working in, to make sure that the environment is safe, that there's no throw rugs, it's clutter-free, adequate lighting, we've got good hallways and walkways that we can see. If they need any safety equipment or assistive devices, we want to make sure that they're aware of those, and tell them to be careful when they're out in inclement weather, ice, rain, snow, where they have at risk for falling, because when they fall they will probably break something. Medications. There are several types of medications that slow the development of osteoporosis, and a combination of several of these medications can be used, or just one. Estrogen, which is a hormone supplement, often we see it as Premarin, and that replaces the estrogen that's lost because of menopause, or if someone's had their ovaries out. And we want to make sure that the clients who are taking estrogen, that there are potential complications, including breast and endometrial cancer, that is a side effect, as well as DVTs. We want to make sure that if they are on estrogen as a replacement, that they're doing monthly self-breast exams, and if the woman still has a uterus, they need to also have progesterone with their estrogen. There's also Evista, which is a selective estrogen receptor modulator, and what it does is it decreases osteoclast activity and therefore decreases bone reabsorption. And we treat postmenopausal osteoporosis women, as well as those who have breast cancer also get this drug. So if your client has a history of DVT, it's not for them, and we need to watch liver function tests with this particular drug. That's Evista, which is a selective estrogen receptor modulator. Calcium supplements, we've all given those. Osteos, one of the favorites, Citracel, and they just supplement calcium that is consumed in food products. And we want to make sure that we give in divided doses with at least 6 to 8 ounces of water. Calcium supplements can cause GI upset, and we also want to watch for kidney stones, because the supplement of the calcium can create a little bit of stone activity. A vitamin D supplement increases absorption of calcium from the GI tract, and this is for people who are not exposed to adequate amounts of sunlight. Now, this could be your elderly person who's in a long-term care facility who doesn't get out. So they may need a vitamin D supplement. It's a fat-soluble vitamin, so toxicity can occur, and symptoms of vitamin D toxicity are nausea, constipation, and kidney stones. So that's something to consider. And then the biophosphonates. These inhibit bone reabsorption. Fosamax is a big one. Bovina, Actonel, these are all advertised on television these days, and it decreases number and action of osteoclasts, and therefore it inhibits bone reabsorption. We want to make sure that we monitor urine output because this drug can be very toxic to the kidney. They are also at risk for esophagitis with biophosphonates, and we want to pay attention if they're reporting any signs of indigestion, chest pain, difficulty swallowing. If they have bloody emesis, we want to make sure we get a hold of the provider immediately. They need to take this with 8 ounces of water early in the morning before eating, and to remain upright for 30 minutes following taking the drug. Very important to remember that with Fosamax or any biophosphonate. And if the osteoporosis is related to the hyperparathyroidism, they may get on calcitonin, which is a thyroid hormone, and that's taken IM or subcutaneously, or actually they can take it nasally and they have to alternate their nostrils. And that also decreases bone reabsorption by inhibiting osteoclast activity. So our care is done by the primary care provider, the nursing staff. Physical therapy might be involved. They might need rehab if they've had fractures or any type of bone or joint replacement. Most hip fractures are due to osteoporosis, and after that joint repair, they're going to need physical therapy for a full recovery. Other therapeutic procedures, there's orthotic devices that help immobilize the spine, like a turtle shell kind of brace, and we can also encourage alternative treatments such as acupressure or therapeutic touch. Physical therapist obviously is involved with the orthotic device, and we want to teach our clients, if they're wearing an orthotic device, to look for skin breakdown underneath it. Surgical interventions for osteoporosis, well, if there's a break, or most often the hip, you're going to see a total hip done. And any complications are fractures. Most definitely fractures are the leading complication of osteoporosis. We want to look for early recognition, and treatment is most important. Osteoarthritis is a disorder that is characterized by progressive deterioration of the articular cartilage. It is non-inflammatory unless it's localized, and it is a non-systemic disease. They used to think that it was caused because there was wear and tear on the joints because of aging, but now they are seeing that new tissue that's produced as a result of cartilage destruction within the joint outweighs the destruction itself, outweighs the production of cartilage. So cartilage and bone beneath the cartilage that has eroded, there's osteophytes, which are bone spurs. They start to form, and they result in narrow joint spaces. And then we have these changes in the joints, which then lead to pain and immobility and stiffness and spasms and potential for any kind of inflammation as well. So early on in the disease, osteoarthritis and rheumatoid arthritis are hard to distinguish one from the other. So I've set up a little table here for you to see the differences and the similarities. If we look at osteoarthritis to begin with, in the disease process, it is cartilage destruction with bone spurs, like I said before. And those bone spurs that are at joint ends, and it's degenerative. The symptoms that individual feels is there's pain with activity, but it improves with rest. It's localized inflammatory response. The individual is usually overweight, and they have Heberdens and Bouchard's nodes, which I have an example of on the next slide. There's no systemic involvement. It's all articular, and it is not symmetrical. Osteoarthritis is not symmetrical, and it's typically diagnosed through X-ray. Now, RA, or rheumatoid arthritis, on the other hand, which we're going to cover later on in the class, but for the sake of comparison, RA has synovial membrane inflammation that results in the cartilage destruction and bone erosion, and it is inflammatory. We see redding, swellness, warmth, pain in the affected joint, and there is pain at rest, and there is definitely a morning stiffness. These individuals often take a whole hour to get up and moving in the morning. It can affect all joints, and rheumatoid arthritic patients are typically underweight as opposed to the osteo patients who are overweight. Some of the nodes, we see swan neck and boutonniere deformities in the hands. There's several photos in your textbook on that. And it can have systemic involvement with the lungs, heart, skin, and extra-articular. It is symmetrical on both sides of the body, and it is diagnosed with X-rays and a positive rheumatoid factor. We may also see a positive ANA with individuals with rheumatoid arthritis. Okay, so with our osteoarthritic patients, we want to encourage them to use joint saving measures, like use good body techniques, any type of devices they can use to help assist them in activities, labor-saving activities, so to speak. We want to have them have a healthy weight, get their weight down if they're overweight, because they are likely to be so, and encourage them to avoid any or limit repetitive strain on their joints, such as jogging. So that's not really a choice of an exercise. Encourage something like swimming so that they don't have such a strain on their joints. Risk factors are age. The majority are over 55, and you will see the joint changes on X-ray. Typically females, once again, they're obese. There could be a genetic link. However, if they have a history of repetitive stress on the joints, like manual laborers or professional athletes or marathon runners, or that repetitive impact type of behavior, we'll see osteoarthritis. So the signs and symptoms: joint pain and stiffness that resolves with rest or inactivity, a history of injury or repetitive stress, and history of obesity, once again. Pain with joint palpation or range of motion. There might be some muscle atrophy. You're going to look for that. See if there's loss of any type of function. Do they limp when they're walking? Do they restrict their activity because of the pain? They may have crepitus in more than one joint, or their affective joints, and if you've never felt crepitus, I'll let you feel my own knees. They may have enlarged joint related to that bone hypertrophy. And there's the Heberdens and Bouchard's nodes. Heberdens are on the distal end of the phalange, and then the Bouchards are in the middle knuckle. Inflammation that results in secondary synovinitis, and that is an indicator of the disease has advanced. So when we look at lab tests, we see an increased ESR, high sensitivity C-reactive protein may be increased slightly, and that's probably related to the secondary synovitis. Our osteoarthritis without synovinitis is not inflammatory. We also are not going to see a change in the ANA, the anti-nucleic antibody. We only see that change with rheumatoid arthritis. Diagnostic procedures, we'll see X-ray or CAT scan, and what they're going to see is a decrease in the joint space itself and bone spurs. Care, What do we do as nurses? Well, we are going to assess and monitor for pain, location, characteristics, quality, severity, all those things. Degree of function limitation. How much does this harbor them? What is their level of fatigue and the pain with activity? What's their range of motion? What proper functional alignment or joint alignment is there? Do they have any barriers within their home? Do they live in a 4-story walk-up apartment? That kind of thing. And what are their abilities to perform activities of daily living? We want to talk to them about using NSAIDs and analgesics prior to activities and around the clock if they need to. Balance rest and activity, so we want them to stage their activities so that they have rest periods between. Instruct them on correct body mechanics. They might encourage them to use thermal treatments, hot or cold, to alleviate the pain, and also complementary or alternative therapies such as acupressure, therapeutic touch, tai chi, magnets, music therapy, all those things. We want to encourage them to use splinting for joint protection, and if necessary, this is also prescribed by their healthcare provider. And any assisted devices and how to safely use those assisted devices, such as an elevated toilet seat or a shower bench, the long-handled reachers that they have, or a shoehorn, those types of assisted devices. We want to encourage them to have a daily schedule of activities. We want them to stay, promote their independence, and to have a high energy activities in the morning, because they're going to wear out through the day and become fatigued. And definitely a well-balanced diet. Probably have a dietitian go in to provide meal planning for a balanced nutrition. So when we talk about the medications that we use in osteoarthritis, acetaminophen, Tylenol, it doesn't provide an anti-inflammatory effect, but that might not be needed if they don't have that synovitis, because it's a non-inflammatory disease. Osteo is non-inflammatory unless they have the synovitis. So if they are on acetaminophen or Tylenol, make sure that we're monitoring liver function tests. NSAIDs, another choice, analgesics and anti-inflammatories they relieve pain, and especially if the synovitis is present. NSAIDs can increase sodium and water retention, so if we want to look at our older people, that might lead to heart failure, pulmonary edema. So we're going to assess for edema, peripheral edema with these individuals, because that can be a possible side effect from the use of NSAIDs. There's also topical analgesics. Aspercreme is one that's been around for 100 years. It can provide temporary pain relief. It depends on each individual. It's applied topically, and it contains salicylate. Capsin, which is capsaicin, it has also temporary relief, and once again it's topically applied. It's made from an alkaloid that is derived from hot peppers. So if somebody's using that, you want to make sure that they're careful with using gloves with them, with the application of these topical creams, because if they touch a sensitive area or a mucous membrane following, they're going to be very sad about that hot pepper on there. They need to reapply frequently, up to 4 times a day, to get the maximum benefit. Glucosamine helps rebuild cartilage. It's a naturally occurring chemical that's involved in the makeup of cartilage, and it's believed to aid in helping rebuild it. We want to talk to clients about appropriate dosing of that. There's also interarticular injections, glucocorticoids they use to treat the local inflammation if there is any. Synvisc is, I'm going to say this wrong, but it's hyaluronic acid, and it's used to replace the body's natural hyaluronic acid, which is destroyed by joint inflammation. and it's currently the only approved to use in knees at this time. So it's a fairly new method, and it is made from the combs of chickens, like the thing on their head. So if the patient is allergic to birds, feathers, or eggs, they cannot have this hyaluronic acid injected into their knees because it comes from chickens. So other practitioners they may see is a physical therapist that's going to help them probably with thermal applications, heat, electrical currents such as a TENS units. PT will show them how to use those things. Perhaps a nutritionist to help them with weight loss and how to control their intake with reduced activity levels. They need conservative therapy that's used for interventions is rest with activity, bracing, splints, thermal applications of hot and cold. Surgical interventions would include joint replacement. And client outcomes, what do we want to talk about there? We want to schedule activities and use conservative therapies that allow completion activity of daily living for our individuals. The clients typically show a slow or stop progression of the disease by making lifestyle alterations. They're able to live with this disease. Paget's disease or Paget's disease is a chronic metabolic disorder where bone is excessively broken down and reformed. The bone matrix itself is structurally kind of disorganized, and that causes bone weakness with with an increased risk of bowing of the long bones and fractures. So these are the bull-legged boys, the cowboys. There's two types of Paget's disease. There can be familial or sporadic. We want to teach our patients about the importance of genetics in familial Paget's disease and refer them to genetic counseling. It's second only to osteoporosis in its occurrence. 80% of people with Paget's disease are asymptomatic, and it's only discovered under routine laboratory or X-ray examinations. And it could be deformity is just confined to one bone. In severe cases, it can be fatal because of the manifestations with that disorganized matrix that breaks down. Pathologic fractures can be the presenting clinical manifestation that they come in with, and once again, we're going to take nursing considerations as to how we can help individuals obtain their activities of daily living, any type of safety measures we can make for them, any assisted devices we need to teach them about, and just help them and assist them. And pretty much that's all we do. There isn't really any other treatment but support. Osteomalacia is a loss of bone related to vitamin D deficiency caused by inadequate deposits of calcium and phosphorus in the bone matrix. Normal remodeling and calcification of the bone is disrupted. Osteomalacia can be caused by pancreatic or liver disorders. It can also be caused by chronic kidney disease and bone tumors. The softer bones seen in persons with osteomalacia have a normal amount of collagen, which gives the bone its structure, but they lack the proper amount of calcium. There's numerous causes of osteomalacia. In children, it's rickets, so they call it rickets, and it's caused because of low levels of vitamin D. Other conditions that may lead to osteomalacia are not enough vitamin D in the diet, maybe not enough exposure to sunlight, which produces vitamin D in the body, or maybe they have a malabsorption of vitamin D in the intestines. Very, very strong sunscreen, such as zinc, can limit the body's exposure to sunlight, and if someone lives in an area where there's short days and high smog factors, it reduces the formation of D in the body as well. Also, elderly who might avoid drinking milk because of the lactose intolerance are at risk for osteomalacia. Other causes could be cancer and hereditary disorders that you would acquire for having vitamin D metabolism disorder. Also, like I said before, kidney failure, liver disease. Anyways, symptoms, we're going to see bone fractures that happen with very little injury, muscle weakness, widespread bone pain, especially in the hips. Symptoms may also occur due to low calcium levels, and if they have low calcium levels, we'll see abnormal heart rhythms. They might have circummoral numbness, so around the mouth, numbness in the arms and the legs. They could have spasms in their feet and their hands. That's from low calcium. So, what do we do to treat this? To treat, it involves vitamin D, calcium, and phosphorus supplements, usually taken by mouth. Larger doses of vitamin D and calcium may be needed for people who can't absorb those nutrients in the intestines, and regular blood levels have to be drawn to monitor the levels of phosphorus and calcium, especially if they have underlying or comorbid conditions to go with it. Usually these people improve within a few weeks. With vitamin deficiency disorders, and complete healing can take up to 6 months. Finally, we have gout, or gouty arthritis. It was originally or historically known as the disease of kings. The most famous king having gout was Henry VIII, or a rich man's disease. And why? Because it's often from rich food. It is a systemic disease where urate crystals deposit in the joints and other body tissues and cause inflammation and a great deal of pain. And it's from a very rich diet. There could be a genetic predisposition or under excretion of urate, which is the salts of uric acid. So how do we treat this? Individual changes their diet, NSAIDs for the pain, and allopurinol to reduce uric acid. Individuals are on your allopurinol prophylactically because they develop gout or they make a lot of uric acid. So that's all we need to know about gout, the disease of the kings.